Assalamualaikum and a very good morning, everyone. Welcome to today's breakfast at UMHealth session titled The Role of Lifetime Medicine in Revitalising Healthcare. We are honored here to have Dr. Sivaneswaran Poobalasingam with us, a distinguished figure in lifetime medicine. Dr. Siva is the founder and president of Malaysian Society of Lifetime Medicine and holds several prestigious positions, including chair of the advisory board for Lifetime Medicine Global Alliance and the International Board of Lifetime Medicine. A board-certified lifetime medicine physician, Dr. Siva is also a key advisor for global organizations such as the US-based True Health Initiative Council and the Global Positive Health Institution. His leadership extends to the National Coalition of Mental Wellness in Malaysia and the C20 Working Group for Integrated Holistic Health in Non-Communicable Disease. Additionally, Dr. Siva served on the advisory board of the International Journal for Disease Reversal and Prevention. His recent work includes being appointed as a lifetime medicine consultant for the groundbreaking Lifetime Medicine Diabetes Mellitus Remission Project, a collaborative initiative between the World Health Organization and the Ministry of Health Malaysia, implemented successfully in one of the public primary healthcare clinic in Negeri Sembilan. Today, Dr. Siva will share his insight into how lifetime medicine transforms healthcare and improve the individual's quality of life. Please join me in welcoming Dr. Sivaneswaran Poobalasingam.
Thank you, Prof. Fadzilah, and a very warm welcome to everyone present here today. Good morning and salam sejahtera. So let me share my slides. Okay, so today we are going to talk about the role of lifestyle medicine and how it can help us to revitalize healthcare. So the learning objectives for today, we're going to discuss the core challenges of healthcare worldwide and how to curb the non-communicable disease tsunami. We're going to discuss what is lifestyle medicine and recognize lifestyle medicine as the foundation of healthcare. So healthcare basically is the prevention, treatment, and management of illnesses and the promotion of physical and mental well-being via the services offered by the medical and allied healthcare. It is the world's most rapidly developing service sector, but unfortunately worldwide, healthcare systems are crumbling and healthcare is in crisis. So why is healthcare in crisis? One of the main reasons is that the rise in costs in recent years has become unsustainable. For example, in 2020, on the back of the pandemic, global health spending amounted to US 9 trillion, which is about 11% of the global GDP. And despite the fact that we are spending a lot of money, but there's a failure of healthcare system to provide appropriate care to the population, which is leading to higher morbidity and mortality rates. Now, what are the causes? Why is it that we are having the situation where we are having healthcare crisis? There are many reasons. For example, some of the reasons will be there's a rapid increase in non-communicable diseases. There's an aging population going on worldwide. And other reasons such as global shortage of healthcare workforce accentuated by the COVID-19, possibly our medical culture where we are over-investigating, over-prescribing as compared to the past when a lot of clinical acumen was used to derive a diagnosis. Today, in our discussion, we are going to focus on the increase in non-communicable diseases and how we as healthcare providers can address this to prevent, to manage, or to reverse it in a more sustainable manner. And we are going to talk a little bit about the aging population in relation to the NCDs. Now, the Global Burden of Disease study in 2010 indicated that there's been an epidemiological shift in morbidity and mortality from infectious diseases and malnutrition to NCDs, premature deaths, and people living with disabilities. Now, unfortunately, as the change took place, health systems are not prepared for this rapid increase in NCDs and the disabilities that accompanied these NCDs. The NCDs have been given the moniker tsunami of the 21st century. And as I mentioned earlier, they are costing a lot of money to treat these NCDs. So according to the World Economic Forum, between 2010 and 2030, the world is expected to spend about US 47 trillion, which means it's about US 2 trillion a year. Now, as a result of that projection, the United Nations had a high-level meeting, and the world leaders signed a declaration, and there were some plans that were put forth to combat NCDs, which we'll discuss shortly. Now, today, 74% of all deaths are due to NCDs. If we look at the global statistics, cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes account for most NCD deaths. Now, very interestingly or very pertinent to us is that 77% of all NCD deaths are in low and middle income countries, like in Malaysia. All right. And what about premature deaths? Premature deaths are people dying before the age of 70. Again, 86% of these premature deaths occur in low and middle income countries. So, which means our country is affected by a high number of deaths due to NCDs and a high number of premature deaths due to NCDs as well. Now, every 2 seconds, that means I say 1, 2, and a person has died prematurely from an NCD. Now, that is sad because NCDs are preventable, okay? And yet, we are having a high mortality as a result of NCDs. Now, if we look at the Malaysian statistics, it's more or less similar to the global statistics. NCDs accounted for 70% of the burden of disease and 71% of premature deaths. And again, if we look at the amount of money that's spent on NCDs, about almost US 10 billion is spent on NCDs, which is about 16% of our healthcare budget. And a point to note is that almost half of that is spent on the treatment of diabetes, and yet we cannot seem to see the light at the end of the tunnel. So there's something not right, or it does not tally, because what we are doing is we are trying to stem the fire or douse the fire, right? Now, let's look at the NHMS statistics 2023. Then we'll understand that why we spend so much of money on NCDs. So if we look at the prevalence of diabetes, 15%, hypertension, 29%, hyperlipidemia, 33%, and people who are overweight and obese, 54.4%. Now, this has gone up by about 4 points from the last NHMS statistics in 2019. Now, this is a very rapid increase, because basically we are saying that half of the country is either overweight or obese. And if you look at abdominal obesity, again, it carrying its own risk factors. 54% of Malaysians have abdominal obesity. So now this obviously is a risk factor for many diseases. Now, if we sum what I'm trying to say, NCDs place a burden on health, social, and economic development. This high treatment cost burdens not only families and governments, and we are always talking about the direct cost of NCDs. What about the indirect costs? The indirect costs due to economic loss, due to loss of productivity as a result of absenteeism, presentism, that means work at reduced capacity. You're present, but you're working at reduced capacity, premature retirement, and premature deaths. Moving on to aging, all right? So worldwide, people are living longer. And you must understand that as a person ages, this increases the prevalence of NCDs and mortality associated with NCDs. So an aging population carries the burden of NCDs if we do not address these NCDs in time. Okay. Now, if you look at the image on your screen from pyramid to pillar. So in 1960, in the United States, all right, their demography was like a pyramid. That means the base was broader, and then it kind of tapered off to a spire at the top. That means more people who were younger, and then it tapered off to a smaller aging population. Now, by 2060, this is expected to be like a pillar. That means the younger generation and the older generation, okay, there's not much difference, right? Now, Malaysia is expected to become an aged nation by 2030, when 14% of our population will be 60 years and over. Now, according to Kazana Research Institute, currently 9.5 years of life expectancy will be spent on poor health due to NCDs. So the healthcare is in crisis. Obviously, multiple remedies have been proposed, none of which confronts the core problem. So why is that? Now, healthcare as we know it excels in acute management. We've got tremendous innovations and developments and technologies in acute management. However, healthcare is not effective at treating chronic diseases. Now, before we move on to talk a little bit more about that, let's just remember that today, 7 out of 10 deaths are due to NCDs. So obviously, we need to shift from excelling at acute management, and we need to embrace how to treat chronic diseases, and the way that we might need to approach chronic diseases will obviously be different from how we treat acute diseases. So some of the reasons that have been put forth as to why healthcare, it's not just in Malaysia, this is a global problem. It's not effective at treating chronic diseases, is that we are very prescription based. We've been trained to be prescription based, and we focus on symptom suppression. Now, we do not address the cause of the disease effectively. Very importantly, we are not able to create awareness and bring about behavioral change in patients. So if we are not able to create awareness and bring about behavioral change in patients, how do we deal with patients who have lifestyle diseases? Because they have a lifestyle disease due to their poor lifestyle. But we expect medication to treat their lifestyle diseases effectively, and they carry on more or less without significant change in their behavior patterns. So globally, after the 20-level high-level meeting, all right, they put forth a UN Sustainable Development Goal, SDG target 3.4. Now, the aim of that was to address this escalating NCDs, and the goal of this SDG was to reduce premature mortality in people between the ages of 30 and 70 from the 4 major NCDs by 1/3 between 2015 and 2030. So when they reviewed this, and they called it the NCD Countdown 2030, which was a collaborative effort between WHO, NCD Alliance, Imperial College, and the Lancet, they found that most countries had made little progress in achieving the SDG target 3.4. Now, this was in 2022. That was 2 years ago. So I don't think significantly much would have changed. So where do we go from here? So obviously, what we need to do is we need to revitalize healthcare. So then comes the question, how are we going to revitalize healthcare? So before we talk about that, let's quickly recap some of the common denominators of NCDs, which all of us know, right? So obviously, our diet, I'm not sure how many of you had your breakfast, how many of you had nasi lemak or, mihun goreng or something like that, teh tarik. Okay, anyway, if you look at the images, which are common food that we eat, all right, so it is simple carbohydrate, simple sugar, isolated fructose, low fiber. I don't see any vegetables and fruits here. Do you see any vegetables and fruits? All right, now look at this. So these are also common foods that we eat, filled with saturated fat and animal protein, right? Now, this is an interesting publication done by a Malaysian. All right, he looked at the dietary intake of Malaysians, and he looked at the percentage of total energy contributed by macronutrients. Now, he found that carbohydrates, we tend to take less carbohydrates at 52%. Now, when we talk about less carbohydrate, don't immediately think about low carb. It does not mean all carbohydrates are simple carbohydrates. We need to take complex carbohydrates as well. Now, so we are undertaking carbohydrates, but look at the fats. We are at the upper end of the scale, right? We're at 29%, and we take a lot of protein at 18%. So if you look at the fat and protein intake, you can then infer that we are eating a lot of animal protein, which carries a lot of saturated fat. Now, if we look at the servings of vegetables and fruits, less than 1.3, less than 1, which tallies with the NHMS statistics 2019 and 2023, that 95% of adult Malaysians, that means like people like me and you, do not take the recommended 5 portions of fruits and vegetables per day. Then we don't need to talk about children, because adults are not able to take the recommended 5 portions of fruits and vegetables per day. Then comes the question, so where are your antioxidants, your vitamins, your minerals, your anti-inflammatory compounds, your fiber going to come from? So then you go to the next step. Look at the intake of fiber. Are you surprised that we only take about 3 grams per day when the target is between 20 to 30 grams per day, obviously putting us at risk for colon cancer, etc. And intake of sugar is almost 3 times the recommended amount at 28.5 grams per day, right? So a diet that is high in calorie, energy dense, and nutrient empty increases risk of many chronic diseases such as type 2 diabetes, obesity, and others. Now, this type of diet that is high in simple carbohydrates, sugar, saturated fat, and animal protein with low intake of fruits and vegetables and fiber will increase inflammation, oxidative stress, ectopic fats, which leads to lipotoxicity and gut dysbiosis. Now, other risk factors are a sedentary lifestyle, plus lack of physical activity, stress, lack of sleep, smoking, excessive alcohol consumption, and poor social connectivity. Now, if we look at the NHMS 2023, let's look at how active we are. So 1 in 3 Malaysians are inactive, 30% are inactive. Then we look at sedentary behavior. Sedentary behavior is different from being physically active or inactive. So half of the population lead a very sedentary lifestyle. So, there's this new saying that we say, sitting is the new smoking, right? Now, we talked about the inadequate fruit and vegetable intake just now. So 1 in 5 Malaysians smoke, 1 in 10 take excessive alcohol. And look at insufficient sleep. This is new in this NHMS survey. Almost 40% of Malaysians have insufficient sleep. So I'm not sure whether people are on social media or is it that they are working excessively, but there's obviously a high proportion of people who have insufficient sleep. And obviously insufficient sleep carries with it its own risk and also predisposes people to various diseases. Now, just a little bit of fun. Let's talk about technology and stress. So if I pose the question to you, if you had a situation where you'll break your bone or your handphone, all right, which would you choose? Now, this survey was posted by this professor called Adam Adler. He wrote this book called Irresistible. He's from the New York University Stern School of Business. And in his survey, he found that 46% said they don't mind breaking their bone. They don't mind a fracture. For the other 54%, they had to deliberate. It was not an easy decision. So it doesn't matter if you break the bone and you're in hospital because you still got technology with you. So life can go on as usual, right? So it is kind of a dependence, feeding our dopamine circuit. Now, after talking about the risk factors for lifestyle diseases and the issue about all the chronic diseases that we talked about, the interesting thing about this is that 80% of lifestyle diseases can be prevented, managed, and reversed. And yet, we are not able to address that effectively. So how do we go about this? All right. Now, if we look at this treatment triangle, this is not my treatment triangle. It is adapted from Dr. Brahman. I find this to be an interesting triangle, so I thought I would share this here. Now, he puts lifestyle at the bottom of the pyramid, and I really agree with that. Okay. Now, why lifestyle should be at the base of the pyramid? It does not matter which discipline we are in, because a patient's engagement in their own health is very important. and they need to maintain the right lifestyle for us to get the right outcome. And it is our responsibility as healthcare professionals to help them get onto this path. Now, unfortunately, this is the gap that we have. We are not trained to get people to get on the path to a lifestyle. All right. Now, of course, in his treatment triangle, the second step, he put it as functional integrative medicine. Then he went on to prescriptions and surgery. So we can remove that functional integrative medicine, and for our purposes of discussion, we can have only 3 tiers: lifestyle, then prescription, and then surgery. But the way I look at it today, I think what we are doing is more prescription first, and then maybe lifestyle, then surgery. All right. So lifestyle is definitely not the base of what we are doing today. So we need to try to reverse that or change that. So here's where lifestyle medicine comes in. So what is lifestyle medicine? For those of you who may not have heard about this, lifestyle medicine is an evidence-based approach to preventing, managing, and reversing chronic diseases by replacing unhealthy behavior patterns with positive behavior patterns. Now, what are its core components? It is a predominantly plant-based diet. Now, don't get me wrong. A predominantly plant-based diet is not equivalent to a vegan diet or a vegetarian diet. I think all of you must be aware of Malaysia My Healthy Plate, which is, or we call it suku suku separuh or quarter quarter half. So if you think about that plate, all right, now half of that plate is fruits and vegetables. Where does that come from? Plants. Then quarter of the plate is grains. So where does that come from? Plants. So 75% now is plant-based. Now, if you remember that diagram, all right, so the last quarter is the proteins. You can take your fish, chicken, any healthy protein. And there's an arrow that, says legumes. So legumes or any plant-based protein, for example, tofu, tempeh, all right? Now, let's say you don't really like plant-based protein and you just take 5%. So that brings our plate to 80%. So MOH advocates that 80% of our plate must be plant-based, just like other countries around the world. We now know that we need to eat a predominantly plant-based diet with some amount of meat. So the meat should be like a condiment. But unfortunately, today, if you walk into, let's say, a mamak shop or, what do people eat? If you go and observe, so there'll be rice, and then there'll be big piece of chicken. And maybe if they wanted to eat something else, they will add on maybe an egg, right? Now, when you talk about eating more vegetables, then people will tell you, oh, it's expensive. So I always wonder, if you eat rice and chicken and egg, how much does that cost you? So why don't you just substitute that, put in some cabbage or something else that is available? All right. Now, other than that, we have the second component will be physical activity, managing stress, restorative sleep, social connectivity, and avoidance of smoking and alcohol in moderation. Now, this is an innovative approach to patient care, all right, where we move away from the prescriptive and paternalistic approach that we have in healthcare, where the doctor and patient is encouraged to form a partnership, where the patient is encouraged to take responsibility for his own health. And the doctor begins to wear two hats, a coach hat and an expert hat. So we always wear the expert hat. We know all about medicine. We tell patients what to do, but we are not able to coach them. So behavior coaching is important for sustainable behavior change, not a fad diet. So they need to be able to change the way they think. They need to rewire their brain. And ultimately, it will fall back to being able to create awareness. Now, a person can only do something when they feel, all right, if I do this, then there's going to be a significant change in my disease outcome, for example. Okay. Now, this is a fast-growing new discipline in medicine that has the potential to reduce the morbidity and mortality associated with chronic diseases. It promotes longevity with reduction in disability, and its interventions include health risk assessment screening, health behavior change, counseling, and clinical application of lifestyle modification. Now, the Malaysian Society of Lifestyle Medicine was privileged to have the then Health Minister, YB Khairi, inaugurate our inaugural Lifestyle Medicine Conference in 2021 virtually. And in his keynote address, he alluded to the fact that the way forward is to create awareness and empower the public to take charge of their health. And lifestyle medicine, an emerging discipline in modern healthcare, could very well be the foundation for healthcare in our quest to arrest chronic diseases and to help our public remain healthy and free of chronic diseases. Now, let's just review some of the research that is linked to lifestyle medicine or lifestyle intervention. So the first one is the European Prospective Investigation into Cancer and Nutrition, called the Potsdam Study. The objective of this was to assess the reduction in relative risk of developing heart disease, diabetes, and cancer. And they looked at 4 healthy lifestyle factors: never smoked, BMI lower than 30, physical activity of 3.5 hours a week, and adhering to a healthy diet. Now, the findings were that adhering to a healthy lifestyle lowered the risk of developing chronic diseases by 78%, diabetes by a whopping 93%, myocardial infarction by 81%, and cancers by 36%. Now, this is an Adventist Health Study 2. It's a large study with over 60,000 participants where they compared different eating patterns with the prevalence of diabetes. And they found that the prevalence of diabetes was highest in the group that predominantly ate meat and lowest in the vegan group. So if you look, vegan is 2.9%, then lacto-ovo-vegetarian is 3.2%, pesco-vegetarian is 4.8%, semi-vegetarian is 6.1%, and non-vegetarian is 7.6%. So obviously, we don't have to become vegan, all right? But striking a balance somewhere in between, we can obviously see that that will bring about desired benefits. Now, this diabetes prevention program was a multi-center trial done with a large group of subjects. And this is not a new study, but it's a very interesting study. The program focused on healthy eating and physical activity. The goals were loss of 7% of body weight and 150 minutes of exercise weekly. And it was to compare lifestyle intervention with metformin to prevent the progression of prediabetes to diabetes. Now, the interesting aspect of this program was that they had a lifestyle coach who helped them with the behavioral change, who did this hand holding with them. So now the patients who were in the lifestyle intervention group, so 58% of them did not progress to diabetes, whereas in the metformin group, only 30% did not progress to developing diabetes. All right. Now, this is Dr. Dean Ornish. So Dr. Dean Ornish was one of the, I would say, the forerunners in lifestyle medicine before lifestyle medicine had, a structured name. So he was doing this, in the 80s. And so let's just discuss some of the research that he's talked about. So he showed that that comprehensive lifestyle change can affect gene expression. They can turn on disease-preventing genes and turn off genes that promote cancer. And he also collaborated with Nobel laureate Elizabeth Blackburn. So Elizabeth Blackburn won the Nobel Prize for her work on telomeres. So he showed that these lifestyle changes can lengthen telomeres, right? So, so the research that he did was lifestyle intervention on patients who had low-risk prostate cancer. And he found that lifestyle intervention increased telomere length. Okay. Now, there are many studies that have been done on lifestyle intervention, telomere length, telomerase, and they find that as short as 12 weeks, they can see a change in telomerase activity and telomere length. So this is the heat map that shows the upregulation and downregulation of the genes pre and post. So the pre is on your left and post is on your right. These are is an image of an angiogram of a patient of Dr. Caldwell Esselstyn. So Dr. Caldwell Esselstyn in the 1990s embarked on looking at heart disease and patients on a low-fat, whole food, plant-based diet and other lifestyle changes. Now, this was a colleague of his who did not feel well for a while, and they investigated and could not come up with anything concrete. And finally, he had a heart attack, and I think it was recommended that he go for a bypass. So he knew that Dr. Esselstyn was working on something, so he decided to give that a try. So he and his wife discussed with Dr. Esselstyn, and they decided to go on his program, and they found that after 32 months, so the stenosis artery, the patency of the stenosis artery improved. So Dr. Esselstyn has published many other research that he has done. So one of it was published in the Journal of Family Practice. Is patients with significant coronary artery disease who have undergone either intervention with stents or a bypass and with multiple comorbidities. So it was a 4-year follow-up studies. And those who adhered to the whole food plant-based diet, 99% avoided any major cardiac event subsequently. And in 93%, angina improved or resolved. Now, in the non-adherent patient, 62% experienced an adverse event. So how do we revitalize healthcare? Coming back to that question. So obviously, we are going with the angle that we need to incorporate lifestyle medicine, all right, so that we can incorporate lifestyle changes in a systematic way, all right, in a prescribed way to the patient. Now, having that done in private practice alone, it's not going to make a significant change in terms of the disease outcome for the public. So it is important to incorporate lifestyle medicine into the public healthcare, into teaching institutions, into new modules, which we'll talk about later. And the second question is how to incorporate lifestyle medicine into public healthcare, because obviously from what I've been speaking, all right, there's a lot of to bring about behavior change, you need to spend time with the patient to counsel them. Now, in a public healthcare setting, when we have large numbers of patients, that's just not possible. Okay, so let's just move on and we will discuss how this can be done, right? So the World Health Organization and the Ministry of Health have a collaborative project in relation to the SDG 2030. And the aim of the project was to build the capacity of a multidisciplinary team of healthcare professionals at a primary health clinic in Negeri Sembilan, which is Klinik Kesihatan 2, and to provide health education and behavioral intervention to NCD patients, in particular diabetic patients. So I was privileged to be appointed as the lifestyle medicine expert consultant for this project, which was the lifestyle medicine for remission of diabetes, and was tasked with developing the lifestyle medicine for remission of diabetes module, and to train and upskill a multidisciplinary healthcare professional team at the healthcare facility. So the goals that were set were to reverse type 2 diabetes and to achieve remission, to achieve weight loss of 5 to 7%, to adhere to Malaysia My Healthy Plate that we discussed just now, and physical activity of 150 minutes per week. So more or less, this was modeled after the DPP program. So we trained and upskilled the multidisciplinary team that included family medicine specialists, medical officers, dietitian, physiotherapy, psychologists, diabetes educators, social workers, and medical assistants. Now, this particular Klinik Kesihatan in Seremban, Klinik Kesihatan 2, there are a few such Klinik Kesihatan that are very well equipped in terms of the multidisciplinary team, right? So this particular Klinik Kesihatan was selected for that purpose. Now, the program that was designed as a 12-week group intervention program. So that means we set the inclusion criteria, the patients were selected, and they came in a group setting, right? So patient came every 2 weeks, right? So we had 6 intervention sessions 5 were delivered in person and 1 was delivered virtually, right? Okay. And so a lifestyle medicine clinic handbook was developed, all right, so that this module, at that point, if it was successful, then it could be duplicated. So this is just an example of an extract from the book. So the patients had, let me just, yeah. So the patients, this is the patient journey, and just going back to this slide. All right, so we had pre-post, because we only looked at diabetes, and so we did the fasting blood sugar, HbA1c pre and post, and blood pressure, anthropometry. And the questionnaire that we gave was looked at healthy lifestyle behaviors and knowledge, one part of it. Second part was readiness to change. Now, these are some aspects that we talk about in lifestyle medicine, because the one size fits all for behavior change does not work. Sometimes patients have their own barriers or their own situations, and we need to help them navigate or teach them how to do it. All right. Now, this is just some pictures of our training sessions. And what was the outcome? So the first cohort, right, or the second cohort just completed. So the first cohort showed that 67% of those who participated in this 12-week program reduced their HbA1c, and 23% had HbA1c of less than 6.5%. And 6 months later, 10% of the patients were in remission, right? So this led to this project being on the WHO website, Empowering Positive Lifestyle Changes with Lifestyle Medicine, a Malaysian initiative to combat type 2 diabetes. So if you are free and you're interested, you can go and listen to patient experience as well as the healthcare professionals who were part of this video. All right. And last year, we had the Deputy Health Minister speak at our 3rd Malaysian Lifestyle Medicine Conference, and he hoped to see lifestyle medicine clinics in each of the government clinics. But of course, it would be good to see lifestyle medicine clinic in teaching institutions as well. And earlier this year, lifestyle medicine experts gathered around the world, from around the world gathered in Doha, and in a landmark step towards addressing the growing burden of NCDs, we reached a global consensus on the critical importance of lifestyle medicine, and Malaysia was also a signatory to the Doha Declaration. So what's happening around the world? I mean, is this something isolated that we are talking about in Malaysia? All right, now Harvard Medical School has an institute called the Lifestyle Medicine Institute. Many hospitals and universities in the US, Australia, and Europe have lifestyle medicine centers, and universities are incorporating modules on LM in undergraduate curriculum. Now, there are postgraduate certifications like postgraduate diploma and masters offered by some universities overseas. Malaysia will start offering our own certification in 2025. We'll start off with a certificate in lifestyle medicine, and then we'll move from there. Right now, we also have the board certification in lifestyle medicine. It is a certification to improve competency. It is not a specialization certification, all right? Now, this year will be the 5th year that we are hosting the board certification lifestyle medicine exam. Now, Malaysia is an exam hub, and now almost 6,700 diplomats from around the world since 2017 to 2023. I don't have the figures for 2024 yet, because the exam is at the end of the year. All right. Now, before I end, I would like to invite all of you all. We'll be hosting the 4th Malaysian Lifestyle Medicine Conference on the 21st and 22nd of November. And the theme of this conference is Diabetes Management Revolution from Prevention to Remission. And we have our keynote speaker will be Dr. Ravindra Abiyasinghe, who's the WHO representative and head of WHO country office to Malaysia, Brunei, and Singapore. Special address by the president of the Commonwealth Medical Association, Dr. Mugaraj. All right, our keynote speakers, remember we discussed Dr. Caldwell Esselstyn. Well, he will be one of the keynote speakers speaking on heart. And Dr. Roy Taylor has done a tremendous amount of work in the United Kingdom on fatty liver and its role in diabetes and in reversing fatty liver, as well as putting patients into diabetes remission. So he'll be also speaking. And we have many other luminaries, Elizabeth Freds, Brenda Davies, and other key speakers from Cornell, heads of lifestyle medicine around the world. Darshan Mehta will be also conducting a post-conference workshop. He's the medical director of the Benson Henry Institute for Mind-Body Medicine, Massachusetts General Hospital, which is a teaching hospital for Harvard. Now, he'll be conducting the post-conference workshop on the 23rd, and this is the first time this is going to be done in Asia. All right, then we have our Professor Fadzilah, who would also be speaking at our conference, and other local speakers as well. All right. So, ladies and gentlemen, my dear colleagues, lifestyle medicine has the potential to reduce the morbidity and mortality associated with NCDs, and it can help to promote longevity. It can help us to revitalize healthcare by addressing the NCD tsunami. It helps to reduce healthcare costs, eases pressure on an overburdened healthcare system, and helps to improve provider well-being, which is a very important topic in today's in these times, right? Provider well-being, and helps us to usher a new dawn for all of us. Now, before I end, I'm just going to leave you with a quote from Dr. David Katz, who was the past president of the American College of Lifestyle Medicine: adding years to your life and life to your years. Thank you, and have a good day.
Thank you so much, Dr. Siva, for a comprehensive talk on lifestyle medicine. I believe lifestyle medicine will be a new term for some of the audience here. So I'm sure it opened up their eye on this field, even though this is a foundation in our healthcare system. I have a few questions from the audience. So can I read it out for you?
Sure.
Yeah. So this audience is asking, is lifestyle medicine the same as preventive medicine? Why create a new name and specialty? Do you see it being developed as a new specialty or incorporated into all interested parties?
Okay, the way I look at it, I think it will be incorporated in all specialities, but mainly maybe under family medicine. All right. Now, the reason why I'm also saying that is that for example, in Malaysia, when I look at the demography of the doctors who are taking the exam, now this initially started with medical officers and family medicine specialists, and now we are seeing oncologists, ophthalmologists, internal medicine physicians, ENT specialists. Like this year, we have got 8 or 9 people from Singapore as well, including a senior consultant from Tan Tock Seng Hospital. All right. So I think it'd be something that is going to be broad-based. So, for example, when I asked the ophthalmologist, okay, I mean, I'm just curious, like, because a lot of them are fairly senior, they're in their late 40s, early 50s. So then I'm just curious to know as well, like, why they're interested in lifestyle medicine. So they say because, okay, they'll say something like, doctor, we see the end stage of whatever happens in the body in the eye, but we want to only deal with the eye, and then we expect someone else to deal with the body. But we should look at it comprehensively. Same thing, like the gynecologist says that, okay, beyond the diabetes in pregnancy and the hypertension in pregnancy, she says we see a lot of people who are obese, people with hyperlipidemia. We've got 9 months to change their lifestyle so that we can have better outcome in the future, but we don't go beyond that antenatal setting. So I think, it's broad-based, okay?
Thank you so much. So basically, lifestyle medicine is across all the specialty. I think that's the foundation of the healthcare. Thank you, Dr. Siva. So there are also another question by Professor David. Thank you for your very informative talk. I smile because as a heart surgeon teaching healthy living in school, I was asking them to put me out of a job.
you have a relevant slide. You are what you eat. How does the profession work with the food industry? How does the profession work with the government to encourage walking and pedestrianize our communities?
Okay, that's a very good question. So, well, right now, what we are trying to do, where we are today, I can talk about where we are today is that, okay, we are now in talks with Protect Health, which if you all know that it is under the Ministry of Health, and they are involved in the screening. So we want to incorporate lifestyle medicine and they are very keen to embrace that as an intervention. So once you introduce that as an intervention, at least the two pillars, nutrition and exercise, okay? And then Perkeso is interested to explore in 2025 how to bring this to workplace. All right. Now, when we go that extra step, because this is a good point, because recently we had this discussion on obesity with a global panel. And again, this infrastructure issue came about because where do people walk? How do they exercise? Now, I'm not able to really give you that answer yet, because that involves a lot of engagement with policymakers, town planning, etc. But yes, I think that it's very relevant because when we tell people go and walk, not everybody is going to go to the gym. Then we need to give them place to walk and safe place to walk as well. Right? Okay.
Okay, thank you very much. There's one more question here. Do you think the profession should be role modeling healthy lifestyle, and how do we encourage the profession to participate?
Definitely. We need to walk the talk. So, for example, like when we have, let's say, okay, let me talk about the Lifestyle Medicine Conference itself for those of you who have not attended the Lifestyle Medicine Conference. So in our conference, we serve plant-based because it's difficult to make it predominantly plant-based. So we say plant-based. So why? As I said, it's not because it's vegetarian, because like you said, we need to role model. We can't be serving chicken, fish, prawn, everything all oily and all that. And then we go out there and tell our patients, oh, this is how you should eat. Then we have a Zumba session. We have a mindfulness session, all incorporated into the conference to give the doctors an idea that this can be done. So I think one of the things that we need to do is, for example, when we have our seminars or webinars, try and curate the menu so that we are walking the talk, and of course, we need to embrace that in our own lives as well. So we need to eat right. We need to try and do our exercise at least 3 times a week, some walking, all right? Practice some mindfulness. Otherwise, when we don't embrace that, how can we tell our patients? Yeah, so I totally agree that we need to do that. And secondly, of course, that's not today's topic, but physician well-being is a big topic, right? Healthcare well-being is a big topic. Stress is a big topic. But we keep talking about it. We need to do something to address that. And, physician self-care is very important. Maybe that can be another topic in 2025. But yes, I totally agree that we need to walk the talk. And these are some of the things that we can do. One, personally at home, encourage your own family, your own children, teach your own children how to do it right. And when you have, functions in your hospital, curate the menu differently, try to be a game changer.
Thank you so much. So is a healthcare professional will be the role model.
Of course.
Yes, I agree with that. Okay. There's one more question here. We should working with the Ministry of Education as well. This starts in school. There was an initiative in the UK, Health School Meal. So I think Prof. David is sharing his experience in UK where they have this initiative in UK, Healthy School Meal. So he's asking, how do we bring this into our undergraduate curriculum? Which I think I've discussed with Dr. Siwa. Maybe you would like to highlight this.
Yes. So I think the question is about incorporating this into the curriculum.
Undergraduate
I think we are looking towards that. So actually, I think initially we are going to be doing micro-credentialing with a private university, but we are really looking forward to developing a small module, maybe like a 12-week. It can start off as an elective because as I discussed with the universities, I realized then, you have all this accreditation and it needs to tie in with that. So it can start off as an elective module. That's what I suggest. And then, and work towards incorporating one module into the curriculum. And one of the Harvard professors that I had a chat with suggested this, and this may also be an interesting thing that we can explore. So she was saying that every block that you do, for example, if you do internal medicine, then we have a small component of lifestyle medicine as part of that. And then if let's say you do, obstetrics, then you have a small component added on to that. It could be a case study, it could be a lecture, that can be one introduction, and then we can have an elective going on to a module. All right. And then hopefully will have a master's in lifestyle medicine in time to come, with Prof. Fadzilah being there. She's one of the board certified lifestyle medicine physicians.
Okay, thank you very much.
Okay.
I think it's the time for us to emphasize this to our undergraduate medical students, which I think we have been doing this, but I think we need more emphasis on this aspect. Okay, so there's one more question. Would like to ask, how related are lifestyle medicine and alternative or complementary medicine?
Okay, lifestyle medicine is part of mainstream. That means actually it is what we should be doing. It is not something that we don't know. It's just that we have not been incorporating it. Whereas alternative and complementary medicine, things that come under that would be things like maybe chiropractor, osteopathy, herbal medicine. All right. Now, lifestyle medicine doesn't go into all that. Lifestyle medicine only focuses on lifestyle behavior. But the difference is it is now evidence-based. We teach the how to. It is not something, it is like no brainer. Everybody knows about this, but it's the how to and the specifics, because what we do, because we are not trained in that area, we are general. And you see, it's like, if I go off a little bit, like one oncologist who sat for the exam and asked her, why are you doing the exam? I'm just curious. So she said, I treat my patients with the chemo and the radiotherapy. So it's not that I'm going to stop doing oncology. She says, then I tell my patients, okay, you take care of your health, don't stress, eat well, rest well. So she asked me, what does that mean? I'm telling a sick patient, you eat well, rest well, don't stress. But I'm not giving her the specifics. So lifestyle medicine teaches us physicians and other allied healthcare, because it needs to also go downstream. All right. The how to. All right. The how to and how to bring about behavior change. So we have motivational interviewing and how to do the prescribing. That means you need to prescribe your lifestyle change also like you prescribe medicine. So that's why, whereas alternative and complementary, like as I said, it's not part of mainstream. All right. They are traditional practices. Okay.
Thank you very much for the explanation. I think people have to know what are the differences and what are the similarities between all this. I think people are still do not get a clear picture, but I think it's a very good explanation on what is the difference between the alternative and complementary medicine. I think this is a very comprehensive talk. I'm very happy to have Dr. Siva here to share this about lifestyle medicine, which I think I was very interested, and I feel like I want to tell people more about this lifestyle medicine. So I think we are almost 1 hour time for our talk. So I think Professor David is currently he is a cardiac surgeon and now educator in Mohd and how I can help. I think, Prof, perhaps we can discuss on how to go about this. I believe that you're asking on integrating lifestyle medicine into our undergraduate curriculum. Sure, I think we can discuss this further. So what I can conclude from this talk is the integration of lifestyle medicine offers a transformative approach to healthcare, focusing on prevention and empowering individuals to take charge of their health through sustainable lifestyle changes. We sincerely thank our speaker for shedding lights on how this approach can revitalize healthcare system and improve patient outcome, fostering a healthier future for all. And both of us welcome everyone to join our fourth Malaysian Lifestyle Medicine Conference on 21st to 22nd November at Berjaya Times Square Hotel. With that, thank you very much, Dr. Siva, and hope to see you again.
Thank you, Prof. Fadzilah, and thank you everyone for joining us on this session. And thank you for inviting me onto this platform. I really appreciate it. Thank you.
Thank you.